Okay, sir. So recording will be start in 3, 2, 1. Please start, sir.
Okay. So, good evening, respected doctors. On behalf of Bayer Pharma, we welcome you all for this today's session. It's my privilege to introduce our esteemed speaker, Dr. Srivachan sir, consultant uro-oncologist at Apollo Proton Cancer Center. Dr. Srivachan sir is highly respected expert in the field of uro-oncology with extensive expertise in management of prostate, bladder, kidney, and other genitourinary malignancies. He has been involved in advancing evidence-based cancer care and is recognized for his clinical expertise and academic contributions. Without further delay, I hand over the session to Dr. Srivachan sir. Sir, over to you, sir.
Thank you, Arun.
Yeah.
Right. So the topic for today that has been given to me is the from MHSPC to MCRPC. Can we delay the inevitable? So the question, the natural history of CA prostate is that the diagnosis is at a state where the prostate cancer is usually hormone sensitive, not castrate sensitive is not exactly the terminology that we use. We use it as hormone sensitive. And over a period of time, as when you start the treatment, you start giving ADT, they eventually turn to castrate resistant. Now, how are these mechanisms that happen? There are various theories. We do not know the exact mechanism. They are the AR mechanism. They are the AR mutation mechanisms. We have the mechanism which is called as a promiscuity. We have, ligands which can still, prevent the binding and so many other factors. But the general concept is that when you have prostate cancer, the biology is so variable that you have several cell lines of variable nature, some of which are responsive to ADT and some of which are not. So once you start ADT, you have a natural progression of some of these non-responsive cell lines to start growing faster and faster. And that is what leads to CRPC. This is the major accepted hypothesis that we have currently. So the concept of triplet therapy came into work because of this theory. So what we want to do in triplet therapy is we attack the cancer cell lines, the various cancer cell lines through various modalities. That modalities can be either through ADT, which will respond, the ADT cells will respond to it, the AR positive cells. And then you have the second mechanism of cytotoxicity, where you can give chemotherapy, kill the cancer cell directly by DNA damage, doesn't have to involve the ARV mechanism at all. Then you have the ARPI, which are the enhanced ADT mechanisms through which you can kill the cancer cell. So this is the pathophysiology behind which the start of the triplet therapy era, which I would say that last couple of years after the P senescence and all those things, the triplet therapy is coming into work, especially in MHSPC, especially in young patients who can tolerate all these drugs, so that their life expectancy is increased, and the surrogate marker of increasing the overall survival is the delay in the onset of CRPC. If you can delay the CRPC, you can delay death. CRPC is equal to death. So that is the concept behind which you are going. So the standard of care has always been ADT. Then came ADT plus, which is ADT plus one of the abiraterone or ARPIs. And there is no role of intensification with docetaxel and all. So we had a concept of ADT plus docetaxel, but now, as the demonstration by Arescens and PIS1, we didn't find any extra advantage by only adding docetaxel. Even in our note, the darolutamide gave a good response without the addition of docetaxel. So there is a possible cause that docetaxel may be an over this thing, but coming to the concept of attacking through three different modalities, cytotoxicity is one of the modalities. So docetaxel still is a part of triplet therapy. So early intensification strategy came through the various previous trials, including Chartered, Stampede, and GITR. So these are the current EAU guidelines. We classify the metastatic hormone sensitive into low volume and high volume, depending on the Chartered or the Stampede criteria, which is completely different from each other, but we generally formed the latitude criteria. And then if they are eligible for docetaxel, most of these patients will be high volume. The high volumes are the one which are most benefited by the addition of a docetaxel. And then nowadays, along with docetaxel, ARPA as well. If you see here, if they are low volume metacrylus or low volume syncrylus, the efficacy favors ADT plus docetaxel. However, if it is, it does not favor docetaxel. However, if you see the high volume and the high volume metacrylus or synchronous, you can see the curve towards the favorable ADT plus docetaxel. So docetaxel is generally added if there is a high risk or a high volume metastatic disease. You can even see the stage wise representation of addition of docetaxel in stage 1 to 3. Not much of curve separation, whereas if you see stage 4, there is a huge curve separation, thereby indicating it works better in the higher stages as well. So the current standard of care for any MHSPC is ADT plus one of the ARPI, irrespective of the timing of metastasis. So metastasis is divided into two types. Either they are synchronous, that when you diagnose it the first time itself, you already have metastasis, or metachronous. Whilst you are getting treated, you develop a new metastasis. So the risk, the volume, the burden, and the co-administration of docetaxel. This is exactly the the RSN's trial, which exactly showed that the addition or the timing of the docetaxel didn't make any of the change to the outcome as well. There is no role of intensification with docetaxel alone, as I already described. So RSN's was the only study prospectively designed to investigate the combination of the triplet, darolutamide, ADT with docetaxel. Now we should all understand that the first cycle of docetaxel has to be administered within the 6 weeks of start of the study. If you are going to do it as after 6 weeks or after 2 months or 3 months or so many things, then it cannot be considered as a triplet therapy. It is a delayed doublet or delayed triplet, or so you can call it. Cannot be a proper triplet. It has to be within 6 weeks of start of darolutamide or any of the therapy. This is a well-designed phase 3 randomized double-blind placebo-controlled trial. A good number of patients of 1306 of MHPC, ECOG of very good ECOG, candidates for both ADT and docetaxel. The extent of the disease, M1A, B, C, were all equally matched. They were classified and randomized into two groups, of which one got darolutamide and other got the placebo. All these people got 6 cycles of docetaxel. The primary endpoint has also been published recently, which is the primary, the overall survival. However, that time, the secondary endpoints were more important because these are all the surrogate markers of primary endpoint. These includes time to castrate-resistant prostate cancer, time to brain progression, symptomatic skeletal event-free survival, time to first symptomatic skeletal event, time to initiation of subsequent antineoplastic therapy, time to worsening of physical symptoms of disease, and time to initiation of opioid use for more than 7 consecutive days. Of course, the safety as well. The final analysis was conducted after 533 deaths. Secondary were tested hierarchically. So this was the peace trial, which is the counterpart of RSN's. Basically, this was a trial which also included triplet therapy. However, the triplet or the third drug was abiraterone acetate. This is not the ARPI. This is the older molecule because this trial was started very early. So this was very similar to the RSN's trial. However, it's an open label study with a 2x2 factorial design only in the EU sector. And the endpoints were very, very similar to the RSN's trial. However, as it was an older trial and as the time took on this thing, they keep amending the trial, which included, ADT was converted to docetaxel 2015-17, and then docetaxel became a mandatory as a part of standard of care. It was also in RSN's, if you see, it is 1306 enrolled received docetaxel, whereas only 710 patients in PEACE received docetaxel as well. So this is a comparison of RSN's versus PEACE 1. You can see the stark differences. One was a recurrent or de novo, whereas PEACE 1 was only de novo. Stratifications were again not very much classified, whereas here it was a lot of stratification was done in PEACE 1. 100% received ADT plus docetaxel, whereas only 61% received docetaxel, and the exclusion criteria was almost very similar as well. So in RSN's, if you can see the curves, the placebo curve was generally quite 50%, whereas the darolutamide curve was 63. There is a difference of 13% of additional value of survival rate when it comes to addition of darolutamide to the cohort. This is very, very important because it reduced the risk of death by 32.5%, which is an amazing difference when you come to the both the overall survival and the reduction of the risk of death in a cancer treatment trial. The validity of the early treatment intensification with the combination is supported by the results from PEACE 1. You can see still the curve, though it is not as much as the RSN, there is a separation of the curve, and abiraterone did add value to the the outcome of the trial as well. However, there is an early separation in the Kaplan-Meier curve, and the line remains separated over the time, as you can see in this thing. You can see the separation right from 6 to 9 months, whereas here it took a long period of time for us to be established as a differentiation factor as well. Patients in darolutamide stayed on treatment. This is very, very important because many times the side effect profile is so much that they drop out of it, or in spite of the drug, they may develop new metastasis, which warrants a change of treatment. And this was the least amongst all the drugs. If you do a de novo comparison, this was the least with darolutamide, which makes a lot of sense for starting of darolutamide as well. So you can see that there was a median follow-up of 43 months, and the discontinuation is similar across both the arms in Aracin, so probably because of docetaxel as well. So darolutamide did not affect the capability to complete the full 6 cycles, did not have side effects that will lead to a discontinuation of docetaxel, which is very, very important. So in Aracins, the grade 1, grade 2 were there, but grade 3 and this thing were not very common, and they were almost equivalent. So don't have to worry too much about the extra side effect, especially if you see this abiraterone, prednisolone in piece 1 had around grade 3 of 217, whereas in plain docetaxel with ADT had 181. This was quite high in piece 1 trial. In Aracins, it was not so high. So darolutamide by itself does not cause increase in the side effect profile as well. For all the drugs that we probably have currently, including enzalutamide, apalutamide, darolutamide, and all those things, I think darolutamide has one of the best safety drug profiles in the current situation. So these are the various side effects in Aracins. It's quite similar to both the arms. So currently, the standard of care of any MHPC is ADT plus one of the ARPAs, irrespective of the timing of the metastasis risk volume, and plus or minus docetaxel. Only docetaxel is no longer the standard of care along with ADT. Almost everybody has voted for triplet therapy. I think there's no doubt in the golden standard or the standard of care currently that triplet is here to stay, and every patient who can, one, not only afford, but also can tolerate it, should be a deserving candidate for triplet therapy. Is patients with high burden, especially, these are the candidates who respond very well to this triplet therapy. Younger patients, higher risk cancer, higher the grade of the tumors. All these are my, those are chemotherapy fit, of course. These are all the patients who I recommend for triplet therapy. As I said, low, probably, they are chemotherapy fit, we may recommend, but I still do not use triplet therapy in low burden disease. So what to consider? Doublet versus triplet. I don't think not much of side effect profile, but then infusional treatment and other things are always there with triplet therapy. So take home messages, 2 studies are only there for triplet therapy, that is piece 1 and Aracins. Demonstrating ADT with docetaxel is not enough. In addition of an ARPA, definitely adds value to that. Additional intensification of the triple combination treatment approach should be the new SOC. It is the new SOC currently. You have to proactively manage the adverse effect of all the new treatment options, and our experience keeps increasing day by day as we do in more and more cases. Multidisciplinary care, a key to success. Of course, we involve the medical oncologist as well. All eligible patients should be offered with the benefits of all proven and effective treatments to enable living with preserved at the same time at the improved quality of life. Thank you.
Thank you, Doctor. Thank you very much for sharing very insightful and engaging presentation, sir. We sincerely appreciate your time and expertise in sharing the latest evidence and practical perspectives in the management of MHSPC. Thank you once again, sir. We will just wait for 2 minutes because if there is any questions from the audience, please post it in the chat box. We are waiting for that. And before that, sir, it's my understanding that, sir, you are the large user of darolutamide. Kindly share your experience in your patient part of your service nowadays.
So I think we have about 5 to 6 patients who have started on darolutamide, and these are all quite elderly patients, though they are not of the triplet therapy. This is based on the arrow note. Most of them are on doublet therapy because most of these patients are usually quite elderly patients who present with multiple skeletal mets and other visceral mets as well. So all of them, in fact, have been doing very well. They have been taking their medication regularly. PSA has been, nadir PSA has been achieved in most of them. And the most important part of all these things, because all the drugs work really well at the initial state, But I think for now, almost a year into the therapy, they have been doing consecutively well. At the same time, the side effect profile was very, very low. The problems we had with the other drugs of other tamides are that apalatomide had a very severe fatigue, nausea, listlessness, and all those things. In Enza, there are some CNS issues and all those things. These two were not seen in darolutamide. That is my main thing in the treatment profile. So, if given a chance, of course, it is a costly drug, and we have our own financial restrictions in suggesting to every patient who walks into my OPD. But if they are affordable, I think this would be my go-to drug in my practice.
Thank you, sir. Thank you very much for sharing your valuable experience. Sir, I think there is no questions from the audience, so we can end the session, sir. Once again, sir, thank you very much for joining the meeting.
Thank you. Thank you
And
so much.
thank you very much for the audiences for joining the meeting. Tech team, we can close the meeting.
Thank you, guys.
Thank you, sir. Thank you, sir. Tech team, can you hear me?